Okay, thank you everybody for coming back quickly from the break. I'd like to introduce, actually before I introduce you to Sharon, who really doesn't need a lot of introductions, I just wanted to point out that we have two guests with us today, two residents from Guyana, PGY1, correct? And this is Kwesi Van Kooten and Mahendra Raganwat. You can correct me. So, maybe you can take a minute to say hi at some point, and if you'd like to connect with any of us, we'd be delighted to help orient you to whatever it is you're interested in. So, welcome. Thank you for joining us. Okay, so I'd like to introduce you to Sharon Johnston. I don't think she needs any introductions for any of you here. She's an associate professor with the Department of Family Medicine, clinical investigator within the CT Lamont in the Bruyère Research Institute. Her research interests are in primary care health service delivery, particularly around performance measurements and how they are applied in the context of chronic disease management and interprofessional care. So that's what her project is about. So how do we measure the performance of primary care, and especially in this era of increasing patient complexity and diversity of interprofessionals who work together? Thank you, Sharon.
Before I start, I just wanted to say that we're very fortunate to have two of my collaborators, Anthony Marr and Simon Boulay, who are both here from Clinician, which is the IT company that we worked with on the transformation project, and who are cooking up this scheme with me. And so obviously all the difficult questions go back there. That's why I'm making sure that as you're writing them, you're putting your arrow pointing backwards. But also just to say thank you for taking time from your busy schedule. I think one of the interesting aspects of this for me is I'm working with, I started in the law and then came to medicine, and boy, is there a big wall between the two of them. And then you try to go business and IT from medicine, and it's not even a wall, it's like an ocean and a wall, and I'm not sure who's paying for it. But it really is, yes, it really is important to start working early on, recognize your sort of limits of understanding, and building things together. So that's kind of exciting. So to have them here, I really am directing the hard questions back there, and that's not just passing the buck, it's also because there are a lot of things I have no clue about, but I need to know, or I need to work with people who know. So I wanted to make sure that you knew that they are here. Some of the other collaborators in this project who you can pick on later, well, Sabrina Wong, who's a nurse researcher out of BC, many of you know, and her expertise is really patient-reported outcomes, as well as nursing care and primary care. And then a couple other characters who are doing their due diligence as teachers. I think it's the structured OSCE testing for our residents. So Liz Maga and Cleo Mavriplis are going and testing our residents. But they are sort of involved in this, and you'll see a little bit why later. We're very early in the stages of planning, so true to research in progress, we're presenting this at a time when your feedback will not make me cry. Maybe a little bit, but we're not at the stage where we've got our heart set on a certain way and then you tell us it's just not going to happen. And also, if you see a role for yourself or something, by all means feel free to jump into the discussion now or later. So thank you for putting this in here. I sent my slides yesterday rather late and did not have this in, but I don't have any conflicts of interest to declare, other than we're talking about a software program, and the people who would be developing it, and have clearly a market interest, which I hope if it works, it will go to market, are here as well. So a little bit of a sort of a what if to put this in the framework where I'm coming from when I'm looking at this innovation. So what if a family physician or a nurse practitioner actually tried to do all of the recommended preventive and health promotion counseling that is evidence-based and recommended in a year? What if? Any idea how much time it would take them? You've all seen that reference.
Yes.
Okay, so it would basically take every working hour of the year, 7.5 hours a day of all of the working days for a year for an average size panel. That study was 10 years old. It was a 2003 publication. The evidence-based recommendations for screening and health promotion have not gone down. But again, some of these things don't have to be done yearly. So if you did it all in a year and you didn't look at a single sore throat and address a single complex patient, in your second year, some of that wouldn't have to be done. So you might be able to see the complex patient or two or fill out a form. But the environment we're working in primary care, like everything else, is not enough time and increasing needs. In primary care, some people like me keep waiting for that IT miracle that's going to find us time, save us time somewhere so we can put it somewhere else. When you actually scan the internet for technology jokes and doctors, there are a lot, but very few are appropriate for a Thursday morning presentation. So I really had to sort of tone it down. But I sort of thought this is like we keep waiting for the app, and we keep going to the app, or our residents keep putting more stamps in our EMRs. But what I'm focusing on is the kind of thing that's going to help us do better and save time. So today what I wanted to do, as I said, is introduce this emerging project, this idea, as well as our collaborators in the team. And one of the things that is helpful is when people say, you probably need this or you should link with that. And that's one of the beauties of being able to present with a group like this. And then briefly to present what we see as some of the opportunities and challenges at the idea stage. And then with that understanding where we would go in terms of our first pass on what our methods and our outcomes would be. And that's where I think people's feedback on what we may be missing or what might be more important would be really valuable. And again, I'll be here to seek feedback. Of course, I started my slides with why I'm really motivated by this. We're practicing in an environment of everybody wants more time. Providers need more time to do what they know they need to do. I just finished a study doing consultations with patient groups across the country, 3 different provinces, where I make them sit in a single room and I close the door so they can't get out for a full day until they basically tell me what is important in their experience. But then my real agenda is what should we be measuring and reporting back to patients. And of course, there's a lot of things that are important that wouldn't surprise you: relational continuity, access. Time has come through very interestingly for complex and non-complex patients. As many are saying, they need more time, they want more time. Many just want to feel like they've had enough time. They don't like this feeling of being rushed. I'm the only family doc in our research team, and I'm sort of going, I don't know how you're going to get that. I don't know how you're asking for more and there's only less. Like everything in the healthcare system, it's do more with less. But time keeps coming through. One of the major gaps we know we have in primary care is preventive health education, health promotion. The studies are showing that there's a pretty big gap between where we think we should be doing in terms of the education and where we actually are. Some of that is time. There are a lot of other barriers for it, but some of it just goes to when somebody's coming in and their agenda is X, it may not be appropriate, or we don't have the time to start swinging them to all of the health education we'd like to get done with them. But it gets back to that more time, sort of setting me up for why we think we're going to be a potential solution. Patients, so providers need time. Patients are also saying that they need more time, and they're also saying that they need to understand better. One of the things I kept hearing working with these patient groups, when we were talking about whether we should be measuring and reporting things like technical quality of care, percent of patients who have their blood pressure measured, who have their colon cancer screening, some vigorous debate, but what we kept hearing is, well, but we don't know whether or not we're supposed to have it. And I have a certain population group where I know you really have to help with their health literacy, and another population group who are coming in and they're telling me what they need. And Dr. Google has already laid it out for them, and I've got the printouts. And sometimes we get a little focused on that group, like they already have it all. But there are still a major group out there of patients who are saying, well, I don't know if I need colon cancer screening. A little bit horrifying for me to hear that, but we heard that clearly across the 3 provinces. Patients still saying, well, how do I know? And if I don't even know, how can I advocate for myself? So there is a need for more role for education and screening from patients' perspective, not just for physicians ticking the boxes that we've done it. So coming from that background, this is our research question as we have it, and I'm aware that there are a number of moving parts in there, and I'm going to break those moving parts down in the next few slides in terms of challenges and opportunities we see in this. And again, we're early on, so the fundamental flaws can be pointed out in this question. But really, it's looking at a feasibility study first to see whether we can develop an acceptable and cost-effective automated two-way email outreach and engagement system. And the major thing we're thinking about here that you can't forget, because it does color everything else here, is we're looking at fully automated. Once the practice says go, the providers have no more role in it. It's independent. So as we're doing that, that puts some limits on what we can do, but it also gets to, if we're going to save time, that piece has to be there. It has to be automated for this to be different from other things that we already have. So challenges and opportunity. You know, can we do it? No, I can't, but our IT team certainly can. We're working with Clinicians who already do an outgoing patient reminder system and the patient appointment reminders. Extreme experience with that, working with many different practices, many different EMRs, so we know that we can do an automated outreach. We also piloted with Clinician an automated survey for patients who consented in the waiting room. Within 72 hours after their visit, we deployed a survey, and we got some very good differences between phone and email. If we're going to talk cost effective, email is the way to go. A lot of people here would have grave concerns about equity, augmenting inequities in health if we only use email. That's something that we would try to build in. But for a cost-effective service, phone is no longer an option. And with the cost of the stamps going up and our post boxes being moved to Canada, which is a problem for me, the stamps, the email system is really not an issue either. We know we can develop the IT to do this, and we can develop lots of IT, but whether or not it will actually work is where this study will come and work and be acceptable and cost-effective. I'll go to my next one. So why we are focusing on email is really largely that cost-effective piece. Phone has very low response rates. Mail has very low response rates, because we're going to get to part of this as the survey back to us. Very low response rates, so the cost goes up because you just have to do so much more. Email seems to be in the middle, but the potential for text or Facebook links and all of that is all there, according to the IT team. If we can make email work, we can make text work. It will change some of the other options in terms of length of content, etc. But whether or not this is a go, if it works with email, it could be adapted to text, to Facebook, to sort of the next generation as well, moving us away from phone and mail. When I'm talking about outreach, and I'm talking about automated outreach, I'm looking at things that can be done that do not require clinical judgment, because you can't be finessing it to disease specific. We would be looking at sort of general outgoing emails, but things that we think are truly important for outreach, with the ability to tailor it to very simple pieces in the EMR, age, postal code, and even we could build in a language code so that you could adapt, obviously French, English, but for a number of us that would be interesting for other populations to be able to get outgoing outreach in the language of their choice. And the engagement piece of this is what really got me excited. I mean, obviously automated outreach that could save time, I think, is worth exploring, but we all know that patients need and providers need more sustainable systems for patients to be able to give feedback on their experience, for us to be able to collect data when it is the right time for us on the things that we are needing information on to incorporate into our quality improvement. But we don't have cost-effective systems right now. The Champlain family health teams all have to do a patient survey, mandatory. Boy, is the methodology for that hugely varying, from a 4% response rate on an emailed survey to the paper-based surveys that we give to our only happiest patients, as we do at my clinic. Hugely varying, but again, it's at least got people moving down that pathway. But it's certainly not sustainable, cost-effective, and right now, based on what I've seen of the uptake of results annually on patient surveys, it's not necessarily tapping into a clinical need. I mean, there are a number of us here who our clinics were surveyed, and I think if you said what was the impact of the last 3 years of these surveys, it would be pretty minimal. We can't keep doing that. We know we need patient feedback. We know we need to be able to get it in better ways, and we know we need to use it, so we have to work on these systems. So with that sort of background as our research question, what we're looking at doing is starting with a single or several site recruitment. The reason we're trying to keep it low is because there's going to be a lot of upfront investment in not the actual intervention we want to do, but readying the practice for this. And that gets to the email. It sounds kind of silly, but email is where many practices are going, but it's very hard to get there. We don't have a natural system for collecting emails, right? They're not attached to your OHIP card. Emails can change possibly faster than addresses. So we need to find the process and help coach the practice, developing with them to develop an effective email database for your patients. We have some experience with that in the Champlain lane with different clinics who've done it, and the CARP Family Health team sort of did it over 5 years, and they have this truly impressive way of keeping it up to date, and it's very impressive. That will be very hard to replicate in the short term, but the lessons learned there could help us really develop the how to get an email database for your practice. And with that, the important things about who is in and who isn't in your email database, which I'll get to. So part of what we would have to do in investing deep with a single or several sites is developing that approach to getting your email database. Then, with any change, especially when you're talking about a change that relinquishes clinical control, you're talking about something automated that will go whether or not you've thought about it to your patients. And we know that there's a discomfort with that. So we need buy-in on what would the content be. That could be an automated email. We're proposing that it would go out on people's birthday, that we might spend 6 months creating an email database, see how many we get within that time frame, and then at the go date, send out an automated email on the birthdays, happy birthday from your practice, and then a certain sort of outreach content. Our practice hours are X, our new programs are X, maybe it's health promotion. 4,000 milligrams of sodium a day is not ideal. If you're interested in learning more about certain risk factors, that content would have to be described based on feedback and comfort level with what can be automated and what the needs are. What are the priorities that aren't being done that we can automate and offload? And then who are our priority patient groups? Is it the 50 to 75, the 20 to 40, depending on what those priorities and what the comfort level is with automating and the priorities for creating time for the more complex patients where clinical judgment is required, who would we be targeting? And that shapes the next step. While we're doing this, we're developing the IT system, is linking the two pieces that we have, the outgoing reminders, the outgoing patient communication piece, the capacity to integrate that into the EMR and link it to pieces of information. Very few right now that we would be starting with because we can get that in pretty much any EMR. Patient birth date and postal code, and then depending on the importance of the other features, maybe a language code. Then develop the content for the outreach. And so that would really have to be based on what we are hearing from that site would be the priority. But some of the things that we've thought of that could be right for this kind of an intervention, obviously age-appropriate screening, who needs a blood pressure annually, who doesn't, even pap smears 3 years. Things like Ontario where they're already sending colon cancer screening, pap screening directly to the patients may already replace this, but even with that, we're still hearing from Ontario patients that they don't know who should get colon cancer screening and not. This is from 60-year-olds, and certainly we're hearing it in other provinces where that isn't as well done. So I would like us not to repeat what's already done by Cancer Care Ontario, but there are loads of other maneuvers that could help us get more efficient visits and get people in, if this works, who may not be coming. If we can link it to the postal code, if we thought that was a priority, we could have a list of resources near somebody. One of the things we don't do well in primary care is connecting people with their community links. We know that. And it's not our job to know where everybody lives and everything that's available to them. But if we could prepare a template of some of the gems, and when a postal code matches that, it automatically goes into their outreach email. That's the kind of thing where we know we're not doing something that needs to be done, that could be done in an automated way. Where we could get innovative and use IT to help us bring the pieces. We will never be masters of the neighborhoods of all of our patients. At my clinic alone, I have patients 3 hours to 3 doors away. That's my range. I can't know their neighborhoods, and I won't. But this could help me do that job of better linking, if that was a priority for the practice or a potential down the line. One of the other exciting opportunities, if we can make this work, is linking to online resources. We sort of assume now that all our patients are online. Some are not, and some are on at places I wish they were not. But this would give healthcare providers the power to push the resources that might be helpful. So one of the things I was thinking when the Citizen article profiled Doug Manuel's death calculator, which I'd happily like us to rebrand, especially if we're going to push that out. But what about online risk calculators or life expectancy? If there's some evidence that some of these resources are helping people understand what their risks are and prepping them for the next visit, should I be on a statin or not? I think that's pretty sophisticated, but even some levels down, helping them get to valuable online resources. In an automated fashion with very little tailoring, it has to be pretty general. But the potential over the next 10 years would be to tailor it much more, disease-specific, community, cultural specific. That could all go once we have this system in play. And then it opens up this whole world of online resources that would come with the credibility of your healthcare providers who have a longitudinal relationship with you, pushing it to you. It has some attractive features to it. And then, of course, there's the practice information, which I think the practices are desperate to get out. You know, what are our after-hours access? We know that 2/3 of our patients don't know what our after-hours access are. That's appalling. And then is that explaining why we still have inappropriate ED use? One of many factors, I'm sure, but this is the kind of thing, new programs, new providers, these are the kind of things that would help market this as a tool that might become cost effective. These are things that you have to do in a mailing right now. We know patients aren't going to their practice websites, but ways of sort of combining pieces that would make this an attractive feature. So what we would aim to do then with this content is deploy the automated email on all or a random selection of patients on their birthdays. Probably, I'm saying, you know, over a 6 month. We're not talking a big budget to test the feasibility, but you're going to spend a lot of time getting a valid email database, and it requires that. So I'm saying that's at least 6 months to say you've got half your practice in there. We can do a calculation on that and really figure out who we would have based on number of visits, etc. But then a 6 month sort of rollout when on the birthdays we send out this. Spreading it out like that has the appeal of the input coming back is a little more gradual or allows you to change things and keep getting feedback. But a practice might say, no, we want it all flu season. Our major thing is to get out this information. Or we want it all right now because we've had a major change in providers or something. And so it's a one-off. Also very doable, but our initial thinking is you could roll this out and you could randomly assign people to receive it or not. There's some interesting features that we could build into it just because it is all automated. And what we would do with this is once we've developed the content, we would also embed a link to a survey, a secure survey. And we have been able to do this, so we know that we can send a secure survey link by email, collect the data confidentially, and meet the needs of the research ethics boards in appropriate practice. My hope is that if you've done an outreach to patients, you've engaged them certainly more than a cold survey coming from your practice. You've given them something and you have the chance to explain, this is to help us serve you better, to increase the response rates to the survey. Because as a data collection tool, which is sort of my hidden agenda for, I think there's a real potential for this as well, you need high response rates. You need people to go to the next step, to the survey. If you're doing it as part of a practice email rollout to 10,000 patients in your practice, you don't need to ask 10, 20, 30 questions. It allows you to have the potential to ask a very few questions and get a lot answered, spread across your practice population. So as a data collection tool, it gets very interesting. And as a way to get feedback, you've got timing potential. You can change those questions pretty easily, just slot them in and out. We want spring set, summer, fall, winter. Maybe that will evaluate things that have changed in your practice, but you could keep your content the same and change your survey. Your survey can be just tailored to that practice, right? You can put pieces in or out depending on what the practice needs. So there's sort of a tailorability to the practice that's potentially exciting, and making this what we've been looking for is a sustainable data collection tool on patient experience that could be embedded in the routine annual work of a practice. Right now, what I see with the family health teams is it's getting us on the path, but it is so not useful right now, and it's just hard to see so much effort going in. So we need to work on the systems that will help us build real patient engagement that's meaningful. And then, of course, collate the data and then either feed it back to the practice, or if this was done for research purposes, sort of aggregating it and getting a sense of regional patterns, provincial patterns, etc. Then, as part of the understanding the acceptability of this, in the survey, we can embed questions such as, is this content appropriate? Would you prefer content on X, Y, and Z? We already know with acceptability if they answer it or not. We've got a pretty good thing, but it will allow us to evaluate the experience of getting an email, an automated email from your provider, and a survey from your provider based on the questions that we pick. So we can assess acceptability from the patient's perspective. From the provider and the practice staff's perspective, we would have to go back to them and work with them, probably in a qualitative way, to say what was the experience of having automated information going out? Are you getting unnecessary visits? Are you getting unnecessary calls back? Are you saving time? Do you feel like boxes were ticked that needed to be ticked that you weren't doing before? So, a number of things that we would be looking at in terms of their experience with this as it rolled out. And also to the practice is patient feedback any more valuable when it's done in this way than when it's a paper-based survey in the waiting room as sort of a one-off, to see if we're getting something that's a little more useful for practices that they can embed into their quality improvement initiatives. So then, with this, some of the outcomes that we could look at, and this is a pretty simple sort of a first pass. This is our feasibility. Can we do this? Is it acceptable and cost effective? The percent, and a lot of this is just that up front, is what are the percent of the panel who give us an email? Who would be included in this innovation? What is the profile of those who are not in our database? We could get that, and that would be your ground of who would be excluded from this. Are we likely increasing inequities in care, or actually are we decreasing them? Because email connection may be, and language specificity might suddenly connect people who previously were not when we were doing English and French mail-outs. But we could study that and get a sense of whether this is the kind of innovation that makes a difference or has potential harms. Percentage of emails that are active. CliniConnects can develop a way to let you know if the email sort of bounces back. And then we have to develop in that the flag back to the practice to say email no longer good. So either change it or flag it next time they come in. Like we can automate that as part of the updating the email database, but also telling us what percentage of people who we think we've sent it out to never even got it, so they're not in our sample. Obviously, our reach rate, that would be opened emails, and that's a pretty good sign of acceptability. And then the reach profile, who are we not reaching? And we may or may not be able to do that based on what data we actually keep, like to the email, who is or is not opening it. And so that would help us answer, can we do this? Who are we reaching? And should we do this? Are we going to be missing some key people that we say this is probably not where we want to go in primary care because we continue to embed exclusions? Whether or not this is acceptable and cost effective really is dependent on that acceptability piece. If we get high response rates from a survey perspective, this will become cost effective, certainly better than a mailing. And it's what we found in the transformation, that if you're looking at the cost effective, the cost of sending out an additional email is fixed. The buy-in to the system is fixed. How many you have to send is what you expect your response rate to be. So if you have a response rate that's closer to 60% versus mailed, which is 30 or less, you have to send that many fewer, and you're now in the ballpark of something that might be feasible for a practice to invest in yearly. Obviously, patient evaluation, they vote with their mouse. They go or they don't. They fill the survey or they don't, and they could have a chance to give us feedback. And then the provider perspective on whether this was a value added to their care, a time saver, a flow process improver, or not. And so that we would be able to describe the experience and whether or not we think that this has upscale potential. And so at that point, it's sort of feedback. And you can see we're early on. We've identified some of the challenges and opportunities, and I welcome the chance to hear from you guys.
Thank you.
We can start with Danielle at the back.
great initiative. I definitely see the potential in terms of pushing information with community resources, and I think that that might also help in terms of not only the after-hours access for mental health, right, to be able to push programs for mental health may address some of the after-hours needs as well. But what would you do in terms of the impact of if you have the worried well, so people who you know are doing well, and then also they get the life expectancy calculator, and then they come back to the provider more frequently because they think, oh, I realize this should have been done, that should have been done, and do you expect that that's going to be a significant impact?
It's a real potential, and that is where we have to look at the appropriate content. And if the gut instinct is that pushing life expectancy counselors is going to drive the worried well, rather open up just 10%, not more than 10%, but even 10% of our patients to sort of look at risk factors and start down the process of thinking about addressing them, that will be, and any of these, the content is very easy to input, and so the content can be changed by the practice level. And that would be, if we feel that it would drive that, it wouldn't go in. If we saw that the provider's perspective was, we have a lot of people who got this automated email and flocked to us to know what their cholesterol levels were stat, then that's not appropriate content. That doesn't necessarily mean that an automated push was wrong, but that was the content that created more alarm. It needed some clinical padding around it. So part of this learning would be the topics that can be pushed with no clinical interpretation around it. And those are real risks.
And then quick question is with respect to the equities, what are the thoughts you had in terms of the cost, the relative cost of, say, an automated phone, like mobile message, so that it's spoken word versus being email, or can the email be spoken word in some sort of form? Just to think about the ways that your email could be made more health literate, right? So pictures and those types of things that, how is the information pushed out? Is there any thought about sort of how you would lay it out to make sure that it is accessible? Because I think I've heard before that even if you translate it, there are people who are not literate, sort of written literate, and they speak another language. So it may not address some of those additional barriers just by translating the language. So we need to put that in.
My sense is that is part of the potential. If this works, this is where we get really powerful potential, is we can match linguistically resources and community and language. We could, and CliniConnex would correct me if I'm wrong, you guys, but simple identifications of like a code in a fixed part of the EMR, illiterate, or something that would create a category where you as a practice would say, we want this email in pictures, or we want this package to go, that you could tailor it. Again, all of this comes with a little bit more cost, but if you had a high population that had this need or this linguistic barrier, you could do that. As a first pass, we would probably go sort of more generic and learn from the feedback. And we probably wouldn't pick up, I couldn't read it or not. But I think those would be things to be aware of. It has the potential to address that down the road, because you can change the content. And that would be probably another study, is working with a subpopulation where you've identified this is already a risk, and then sending out tailored content, and do their response rates improve? But the potential is there.
Well, Mahendra, did you raise your hand? Oh, I thought I saw that. So Alan, and then maybe Diane, and then.
I'm a bit confused on the tailoring bit, even though it's down the road. So if you saw a patient today and he was still smoking, is there a way you could click something on his electronic record that would mean his next email would say, we remember that you were smoking at your last appointment and wondered if you've given this any consideration? And then I guess the second question I would ask is, will you have a make an appointment button on the email? Because that's another thought that, someone just, I should do this because you tell me to do it tomorrow all again.
That's all the really amazing future. The Rockland Family Health Team has online appointment booking. You go in, your personal code, your nurse practitioner or family physician schedule pops up with available slots, and you can do that. So the future could embed that in. Do you feel you need an appointment? And that's what you want to do, is capture them when they've done this life expectancy, and you don't have their worry well, or you do, we'll see, and then they go ahead and they book their appointment, and you close the loop, you make it as easy as possible. So that is all part of the potential that we can embed in the system,
Right.
which gets really exciting. you first have to show that it can work, that
For
you
sure.
can, go via an email or a text or something. But that's why, like, it's hard to get ahead of ourselves, because the down the road features really tailoring. And Anthony and Simon have said that as technology progresses and they will work with other companies, they could get things coming from the EMR content, right? We are stuck with just a fixed profile, but eventually EMR content could be provider driven to give a code that then triggers something.
Yes.
No longer perfectly automated, but powerful. Or EMR things could come out like you have not had X, and that triggers a code, and that code triggers the service. These are all down the road potentials that you could build in where you could really see us closing the loop, what we have on you, out to you, and then back to the practice.
I also wondered about whether OHIP would ever consider attaching an email address to your OHIP number, so when your receptionist swipes the card, the address pops up. Or, like, I assume the receptionist would say, has your email address changed? But if you had it on the card, I know that's probably
And we'll
3 steps
have
down
to
the road.
watch that one. Email was such Pandora's box up until sort of a year ago, and now the move is more towards portals. What I'm hearing from some of my patients is the portal sends you an email to go to some site, people check the email on their phone, and then they delete it. So we have real issues there, but that does seem to be the future. But if we developed emails that had no personal health information content, then they can go out just straight emails. OHIP would be a problem because they're concerned about getting in the mix of insecure personal health information. But you can get around that. You can do straight email, no personal health information, or via the portal if you want to get more fine-tuned.
This is where your law background is especially helpful to you. Diane?
Well, I thought it was interesting when you were talking about equity and leaving people out. And we already know that probably our older senior cohort may have trouble. But I guess the other issue is that we do already have problems with equity and people being able to access our services. And we often don't know who's not accessing our services. I mean, the Syrian refugees are giving us some challenges with language barriers, plus cultural barriers. So I guess one of the things is that I think you have to argue this one from the other side, is it is part of the future, the way of the future, and we do have a demographic that are on email and tech savvy, and we have a group that we have to be aware of. But it is not that this is going to be, I mean, if it's a barrier, I think you just have to understand which populations can't access it. It's interesting with the accessibility with the university, they're taking websites down because they aren't accessible. Well, then they're accessible to no one. So we have to be careful to, the whole idea of, what we're talking about when we think about accessibility, because currently our patients are loyal.
Yeah.
It's when they show up, we do something for them, but we're not reaching out to
Right.
them.
And if we knew, it doesn't mean that this doesn't work, that it's excluding 20% of our very oldest patients, a very important group. But you address them and know that this solution that we've got that's automated and hopefully saving us time is not for them. Maybe they get the mailing. Maybe we have a separate, anybody who doesn't have the email gets a mailing, but we've reduced our costs already. But you need to know that. My fear would be that we send out email and we drive the worried well into the practice and we drive the great self-advocates to the programs. If we know that that's what this is going to do, then we set up parallel mechanisms to reach those we don't. But we need to know. And so that's why I'm saying we could figure that out by simple measurements embedded in developing this. So as primary care providers, we want to save time, but we also want to do good. First, do no harm and not enhance this. And we're all aware that as we embrace technology, we are leaving some behind. We could at least figure that out, and then it's for the practice to decide what you do with it. But we would be honest from the beginning, not saying this is for everyone.
So I've got Doug, Claire, Lise, and if we've got more time, we'll take more.
Two comments, questions, Sharon, about engagement. Okay, the first has to do with theory, okay, and an up-and-coming theory that's becoming popular in terms of engagement with technology is social materiality. That's how people engage with the given technology. I think it might be a very good fit. There's two people that you should read, I think. One is Anna McLeod of Dalhousie, and she's used this theory for distributed medical education. And the other is Tara Fenwick, and I think she's in the UK now. She's originally in Canada, and she's done a lot of work around simulation and using this theory.
It was
So I think-
McLeod?
Sorry, Anne McLeod. And the other is Kara Fenwick.
Okay.
Those are, I'd be interested in hearing what you think and see how this sort of fits with it. And the other piece around engagement, again, and I don't know if this will necessarily get at equity, but around your target audience, if you choose an older demographic or a younger demographic, is how they are using technology. In terms of whether emails are used, and you mentioned the challenge about emails changing. But again, to pick up on Danielle's point about the texting features, and how that may also be an avenue to explore. I know that like with WeChat, for example, I mean, it does have those translation capabilities that are sort of built into it. I mean, it adds complexity, but it would be interesting to see what the engagement is in these different technological venues.
And Clinician does that. They send out, they do automated outreach via email, text, and you were saying, connecting with Facebook isn't even that far down the pathway. And I guess that's what we would have to look at. The limits I have is truly the content. If you're actually looking at meaningful outreach, there could be very small messages often on text that could be great, but that's probably more specific, tailored to smoking cessation, physical activity, where that would absolutely be sort of the future. We're looking at, a bigger and a clunkier first pass outreach. I was thinking that would be more acceptable to patients, and we can't tailor it so much just yet. But to be studied, and then I would see the future as allowing people to specify and absolutely following them where they go on their mobile devices, but that would probably be more tailored messages. Which you could do the same pattern link with like a practice outreach. By the way, we've opened up a new Thursday evening clinic. Have you thought about making an exercise goal of X? And there's also study potentials in that. What push messages make a difference in the long-term outcomes that we could study from it. So it is, the capacity is there. What we would be limited by is what's our goal. If it's smaller, shorter messages, that's definitely more amenable to other types of interfaces. If it's a little bit more like our typical, we like to give a little bit of background and explain why sodium is good and bad and what the molecular structure is, that's probably email. Or we should be paid by the word.
I'll just say, I think we can actually use this almost as a practice management. Some people who are going to be on email, and I actually think the seniors are probably more likely to respond to a specific email than many of the other groups who need to Snapchat or whatever. So then you got people you can deal with in that very kind of automated way. You probably don't even need to see them. You're going to do well. You got people who are going to need that portal interface, and we all know, I'm loving the portal, but their patients, there's no way I'm running on that portal. And then you've got people who don't answer those emails, and maybe those are the ones you scoop up in a basket and try and tease out for what kind of services they need, right? They may need the face-to-face or the team-based approach.
The first thing is we can identify that. Embedded in the approach is collecting that. So you at least start with knowledge. You start with who you're not reaching, because they don't have the email, because they don't open it. You could collect that, and then you can make decisions. For this to be marketable, my sense is a fair amount of the people have to choose the venue that you're going with and open it. And then you can say you've done it and it was worth the 30 cents an email or whatever the cost may be. I just pulled that out of the air. To go, well, what's a stamp, right? What's a stamp for one-off communication? But we could capture that, and then you can say what you're doing. So you can embed in this the capacity for ongoing learning and improvement. Please. Do you still remember your question?
Yeah. Just on a philosophical level, I'm just overall concerned, and I mean, I do, email is and other means of communication that require a screen interface are here to stay, but I'm just concerned about the proliferation of things that we have to do through our screens, and I'm thinking about kids' homework in school, and if you now, you get an email from your practice and you're looking up, like, it's just, we're contributing to the time that people are spending sitting down in front of a screen. So I know it's probably a drop in the ocean in terms of going against the trend, but I do like the idea of at least having the option, for example, of an automated phone message. It's much more efficient to speak than to write or to type or to have to turn on the computer and go into your email. So giving that option to people, saying, would you like a monthly reminder about preventive, things that you can do to improve your health or whatever, by phone and or email, and let them click. I think that at least gives people the option, because we're doing everything. We do our banking, we do our kids' schedules, we do registration, we do everything in front of the screen.
We
And
did
then
that
we're
for
supposed to tell our
transformation.
kids to not, to move outside for an hour a day.
For this to work, it has to be cost effective. This is gonna cost money to practice this, right? This
But
isn't
if
a
we're
service
talking
for
about
free.
an automated phone message, I'm not talking about
Yeah, but they're not
somebody
picking up
sitting
the
there.
phone. They're not
Yeah.
answering.
Yeah, but does that cost anything if somebody doesn't answer? I mean, the cost of making the message and having the computer dial a whole list of numbers is a fairly fixed cost, I would think.
Most people have answering machines, so you have to do something, like a lab, you have to leave something.
Yeah, so you leave the
And with
message
the
on
phone, you have to
answering machine.
confirm that it is the person, et cetera. So confidentiality-wise, the phone is much trickier. You've just identified that they're now linked to your practice and you don't know who they are. So it is tougher, but it is a medium that can absolutely be used. Very short, because you can't go and give a full page in a phone, your time is limited,
Of course
much
not.
like text is, but they will appeal to different groups.
Exactly.
They can be brought in.
And I believe people should be given the choice of, like, you could say phone, email, text, and they can click all three of them if they want to, or just one, or both, or, so I think giving people the choice.
This debate can go on.
Yeah.
You've heard it's a
Yeah.
very, very
Just
relevant debate. No, back and
thought,
forth.
because,
We've got 2 minutes left, so I just want to hear, Danielle had a comment and then Kevin, so.
So I was just wondering what you've done or thought about for patient engagement. So do you have someone in your planning team planning how you're doing this with a patient of more than 1 or 2 or 3 patients in terms of this early days
Because
planning?
we could help you with that.
Shameless plug, yes.
No, we don't have somebody engaged in the actual small team right now. This is obviously something that I've been discussing with the patient groups in terms of what has worked for you in terms of interacting with you. So I've been floating this out to see whether people are interested in, from a patient's perspective, getting like feedback from patients across the country, but nobody was working with us to develop it.
I highly recommend. I think there's a lot of really great patients out there who can give you that perspective, which may save you the time of trying to do the experience type of engagement later on. It brings it at the forefront. So.
Yeah.
And you've connected with Alice, right?
Yeah.
I've connected you by email,
Yeah.
so there's a start there.
No, because he said by email.
That's right. Well, we hardly ever walk people to people's offices anymore.
I know,
Even when we're right next door. Kevin, did you have a comment, or do you still remember it?
Yeah, no, I think this is interesting. It's early. You definitely need a more multidisciplinary team, I think. I feel stressed with this presentation because I have like hundreds of emails and I really don't want my doctor anywhere near me. I don't even answer most of my emails. I didn't even go there. So my kids don't do emails. I can't email them. So I guess I'm just wondering who is it that's doing emails. So. But I'm just saying, but the technology element is there. So you want to communicate to people, outreach. But I'm not hearing you talk about extending the patient in-person visit relationship to an outreach visit, which is what I always think about when I think about going outreach. Sometimes I see them in my clinic, sometimes I see them at the home, sometimes I see them at the shelter. But for me, it's like, it's a continuity of relationship in different settings. Here, I feel like you're pushing something out that is totally like not personal, very personal.
Yeah.
You say it's personal, but I don't think it's personal.
It's not, it's automated.
It's automated.
It's to try to create time for the stuff that does require relationships, clinical judgments.
I guess,
And not everything is right for it.
So I guess I just feel like there's gotta be more theory and investigation focus groups around this kind of stuff, because if I was there, I'm very concerned about this. And I wouldn't, like, I would like to support you though, I mean, actually, I think the challenge for me though is I'm feeling over the hill, just had a birthday, and wondering if I can really keep up with technology and understanding, where this is going, and then maybe you guys, your job, right? So you guys seem confident enough, so maybe it's okay. But I'm not confident that this is the future. The future is outreach technology using computers, yes. So I agree with that 100%. So I'm just trying to think about the relationship and how this could affect it and all that. So I'm not hearing potential harms from this, which I really worry about. And patients getting the wrong messages, getting worried, scared, and all that kind of stuff. So that's all. It's just kind of a word of caution.
Thank you. I think you could have a lot of discussions with folks, certainly lots of interest, and I encourage people to continue the dialogue with Sharon. Thank you very much, everyone. Thank you for coming. Can I give you a last word on anything? We really didn't give you an opportunity to, is there
We're just here mostly to listen. We were here mostly to learn and
Yeah.
learn.
Yeah.
I think Sharon did a very thoughtful job in presenting.
And it just gives some context. Our automated outreach program is already in place across Canada. Used by over 1,500 providers. So this is not like this hasn't been done before. It's being done by voice, by text, by email, TeleCMR, QHR, EMR, Oscar. So
Family health team.
APTO is aware of this. So we've got the fundamental pieces in place. Now we need all the clinical input, which was great to hear. That's what we don't understand. It's what's required. So thanks for the feedback.
Yeah, thank you everyone for coming up and for your comments. It's really important. I mean, it's really important to hear your voice, and I'm